Thank you, Chris.
Thank you, Mr. Chairman. And as you can see, I put a question mark there, because I'm neither here to praise nor damn tapes. In this context, I think it's very important to look at the evidence base, and we're all aware of guidelines that exist using PICO analysis, in other words, to look at the evidence as it exists. And I think it's very important to consider the evidence for all of these procedures very carefully, as we've heard already from previous talks. It's very important to obviously think of the symptomatic benefit, the evolution of the assessment as we see it in the multidisciplinary team approach, and also to look at the outcome for the patients, not only from the surgical perspective acutely. Let's face it, we always think we have fantastic outcomes, but it's the patients that live with the consequences, because ultimately one's got to consider their expectations, the goals they set, the achievements that they want to get out of what you're doing, and the satisfaction which they actually have a year or so down the line. Of course, one of the problems with evidence base is that the lack of evidence, particularly when it comes to surgery, as we've already heard clearly emphasised, looking just at, for instance, sphincters. And at the end of the day, also common sense comes into it, as you will no doubt recall this paper from the BMJ, which pointed out that we haven't got any evidence that jumping out of a plane without a parachute is a bad idea. Equally, we haven't got any evidence that examining a patient is useful if you look at the evidence base. Now, if you think about sling surgery, it goes back over 100 years. So if you look from the right to the left, there's no doubt that autologous material, which is a form of crude tissue engineering, is the most effective treatment. It's got a low failure rate, a low complication rate in expert hands, but of course there's the morbidity from the donor site. We've seen over the years a myriad of treatments. We even heard some discussed this morning, potentially. And we know that xenografts don't work because they elicit a T-cell response, because they're foreign material. Or the same goes for allografts, and we've seen cadaveric tissue come and various other materials from humans which are allergen-free. And at the end of the day, a very high failure rate, so they've all come and gone with great fanfares when they come in, but very little when they actually go out. And we know that synthetic material is certainly very effective, but we know it hangs around and is associated with potential complications. So there's no ideal material, and so we need to see what we have at present. Sling surgery's been around, as I say, for over 100 years, and of course the actual format of the sling doesn't really matter. At the end of the day, as long as it's in loose, when I was training, we were taught to put them in attached to the rectus fascia, which is rather nonsensical because it's not likely to have a blood supply and did cause a lot of pain and morbidity. That's evolved into taking the sling out, and obviously following on from the Stamy-Raz approach, we had the full-length sling which you could pull in, and of course that led on to the Tim Stevenson and Malcolm Lucas sling-on-a-string approach, which I've used for 30 years and which is very effective. At the end of the day, you don't want to put it in tight. Just like for synthetic sling, you can put it in midurethral, and although this diagram looks at the bladder neck, it's wrong. I always fix it up midurethrally, but I emphasize that because people always tend to think of this as being a tight sling you put in for sphincteric weakness, which it isn't. In this context, you put in just as loose as a so-called tension-free tape. And indeed, if you look at the randomized study from the States, note the colpus suspension on the left isn't really what most urologists would call a colpus suspension, but they compared these two procedures where people were adequately trained to do it, and you can see the success rates were very similar. But again, at the end of the day, it depends on what you count as success. Marketing always comes out with the 80% figure, but if you look at the criteria do vary depending on what you are actually looking at. There's no doubt that slings, though, do cause more voiding symptoms, dysfunction and storage symptoms than colpus suspension in that context. And if you look at the 2-year data from this study, it showed that urodynamically there was more obstruction with a sling put in according to the criteria that they had suggested. The 5-year data, though, didn't show a great deal of difference in terms of the objective or subjective outcome relating to sling versus colpus suspension, but there was, of course, more secondary prolapse relating to colpus suspension, which is reported separately. Of course, others have looked at the evolution of the Stamy-Raz approach, and Philip Zimmerman, who's going to be speaking, has pioneered an approach which is to use multiple sutures, which actually produce the same as a colpus suspension with suture material with very good results. Of course, the tension-free vaginal tape is a marketing term. TVT came in. It was certainly an advance in the field, and the principle which you're well familiar with was to put in the tension-free tape, so-called a loose tape, which was put in per vaginam. So, of course, there's been work which has been looking at this, and the pioneer study was that of Hilton and others, and this is a 5-year paper. Now, I think it just asks you to focus on the basis upon which slings were put in. You can see the numbers involved originally from the study against Culper suspension. Not huge numbers. And indeed, if you look at the 5-year follow-up data, you can see that very few of the patients were followed up for 5 years. But of the evidence that was available, we did find out that there was an erosion rate of around 4%, which was reported in a letter to Neurourology Urodynamics. And if you look at the objective and subjective outcome parameters, just as for the previous study, you can see it varies. The marketing always would suggest the success rate around 80%, of course. Of course, based on that, we then saw this approach, and we're all familiar with what's happened in the market. So based on one paper, we had all of these things approved using polypropylene, which actually was used because it had been acknowledged as successful for the Liechtenstein abdominal hernia repair, which is the reason why polypropylene was used. There was then a lot of nonsense about it being very biocompatible and giving with the tissues and so on. But if you look in a laboratory situation, over a week's distension, it becomes string-like, as all of us who've taken these out are well aware. Of course, there was then a foray into prolapse surgery. If you look at the evidence base, which I've been asked to do, then if you look at the literature, there have been, of course, a number of studies which have looked at meta-analyses, 39 papers, in fact, in this analysis in European Urology. And essentially, if you look at the evidence in the literature, midurethral tapes versus Culper suspension, very comparable if you look at all of the parameters, with very little difference. If you look at midurethral tapes against pubovaginal slings, they looked identical here too. But it's all very well looking at the literature, as you know, because the studies are all carried out by different individuals with different parameters and different settings. So, of course, whilst you can say that they look comparable, the ultimate is to carry out a head-to-head comparison. If you look at the next approach, that was the transoperator tape from Delorme and others in France, and if you compare the retropubic tape against the transobturator, the literature again from that analysis would suggest similarity. The logical thing then was to carry out a head-to-head comparison, which was carried out in the States, the so-called Thomas study. And they worked out from the statistics looking at the numbers that a plus or minus of 12% had to be overcome to show difference. And they looked at both objective and subjective parameters, and you can see from the numbers here that there were reasonable numbers in the study in both groups. And just cutting to the chase, looking at the 2-year data, no surprise that retropubic slings, even in the context of experienced hands, had a morbidity rate. Of course, perforation of the bladder, if you recognize it, is not a big issue. But you can see there that there was a 4% at 2 years in experienced hands in this network study, tape complication rate. This is in the peer-reviewed literature, of course. But if you look at the data 2 years, you can see that both TOT and TVT did not, according to the statistical plan, actually differ in their efficacy. That's just 2-year data. Of course, one mustn't forget, going back to Malcolm Lucas's study, and myself and Roland Morley were involved in the study. You can see, looking at the literature, this is a small number, only 60 in each of the groups, TVT and autologous sling. We had to drop out the material from porcine origin because at 6 months it was failing in this randomized study. The Bard company weren't very pleased with us and complained about it at the time, but of course they subsequently dropped it from clinical development. And if you look at the literature for dryness, you can see that indeed the autologous sling was at least, if not better, than the TVT procedure. And of course, the material from porcine origin really didn't even register there. So this then led on to the single incision sling, and you can see the single incision sling, we've already seen a diagram along those lines, really at a year in this French series, the TVT Secure already failed and was withdrawn from clinical development. Of course, it wasn't introduced with any trial data. We have seen other single incision slings come along. There's about 95 in each group here, and certainly they look encouraging. But if you look at the evidence base, and this has been reviewed by the Cochrane group, group, you can see that the suggestion there was if you take out the TVT Secure, certainly the evidence is that they may be as effective as the other slings, but we don't have long-term data, and you have to therefore consider these not to be a replacement for conventional slings, but at a level at which we are not yet sure if you're counselling patients. And so that needs just to be borne in mind. Certainly, of course, the single incision sling has the advantage of speed, less morbidity, and so on, but at the end of the day, time will tell, and it may be just as effective. If you look at the guidelines, from the AE guidelines, you can see that's acknowledged there, and you can see that the alternative slings are, of course, recognised as being effective. I've gone back to 2012 before the latest Ferrari started, and you can see this is the UK experience. We were putting in around 12,000 TVT or TOTs in the UK, and of course you're all familiar with some of the patients that present. It's not very common, but when it does present, it's now, particularly with all of the literature in the newspapers, causing some interest. And of course, you're seeing that manifest. We saw the issue with Scotland, where it wasn't banned. The MHRA actually put out a warning, but the politicians picked up on it, and so that was then blown a bit out of perspective. Nevertheless, of course, the responsible bodies have come forward with lots of suggestions as to how to improve this. There's European law being drawn up at the moment relating to this, which is topical. There's an expert report that's just been released in the European Parliament, and of course they've all come out with suggestions. Remember, the responsible bodies aren't responsible for efficacy. They're responsible for the safety of the material. It's devolved to the companies to follow up the data, and it's their responsibility to do that. But how many of them have actually done that? And I think this is actually something that's going to come into the law relating to that in due course. Of course, there have been suggestions that come forward. This is a group that worked with the MHRA in the UK, and this is another group that worked to provide a European Association report with the suggestion, of course, you need to counsel patients, you need to know what you're doing, you need to have sufficient numbers. And in the UK, that's manifested in us now working in MDTs, specialist groups doing this, and if people can't justify their numbers, I think in a few years' time they're going to have some trouble actually explaining why they've carried out the procedure if they have a complication. So, we have excellent BAUS information leaflets, and I recommend that you look up this one, which gives your patients all the information that they require. I think at the end of the day, it's a balanced approach to the use of these materials. Over the last 25 years, I found a third of my patients have always gone for an autologous sling, and certainly in recent years, if I counsel them accordingly. And certainly I think it's now manifest on it's our duty as urologists working in this field to tell patients about all of the risks and benefits, give them a written information leaflet, and then based on that to treat them accordingly. Thank you very much.